Hello, my name is Chris Lim, and I am the Royal College of Physicians and Surgeons of Glasgow Trainees Committee representative. You will require a number of different assessments as evidence of your development in IM Stage 1 training. These are known as Workplace-Based Assessments, WPBAs, and this video will focus on a particular type of WPBA known as Supervised Learning Events, SLEs. The first type of SLE we will discuss is the Acute Care Assessment Tool, or ACAT. This is designed to assess your ability to manage acute patients. However, rather than just purely concentrating on your clinical reasoning, it also assesses your ability to organize yourself, multitask, and prioritize when managing several acutely unwell patients. Thus, it is not simply a multiple case-based discussion and should not be used as such. The ACAT is usually used for patients seen on the acute take and performed after reviewing them on the post-take round with the consultant. However, it can also be used for new patients admitted to a ward or day hospital. For example, if you review all of the new patients before the morning consultant ward round, the ACAT can be performed during the ward round. This is particularly useful for those of you on clinical attachments where there is no acute unselected take. The take is very limited, or the arrangements for the post-take round makes it very difficult to review the required number of patients with the same consultant. You must have reviewed each patient and created a plan for their ongoing management. For a valid ACAT, you need an absolute minimum of 5 patients. Any less than this and the assessment could be rejected when your e-portfolio is reviewed at your ARCP. However, you can include more cases in the assessment if you wish. ACATs can be completed by any senior colleague, such as a registrar or a consultant. A minimum of 4 ACATs must be completed by consultants. We recommend checking the decision aid for further guidance. You require a minimum of 4 ACATs each year of IM Stage 1, but we would recommend obtaining more than the minimum. This is because ACATs will be one of the most important forms of evidence that your educational supervisor will use when determining whether your level of entrustment for clinical SIP1 can be rated at level 3. This is critical for enabling you to progress through to IM Year 3. The need for this assessment should be indicated by the trainee before the patients are seen with the assessor. This is to ensure that the assessor has adequate notification of the issues that should be considered within the ACAT, and also so that appropriate timely feedback can be given. The need for the ACAT may be confirmed after the actual assessment itself by sending a ticket via the e-portfolio. Make sure you provide details of each patient case in the ticket request. The assessing consultant should then copy these into the assessment form. It is vitally important that you do not put any identifiable patient data in the ticket request. The case-based discussion is an assessment of your clinical reasoning, management, decision-making, and medical knowledge in the care of a particular patient. They are performed following discussion of the care of a particular patient, and you should be familiar with them from your foundation training. They can be used in all situations, but are especially useful in the outpatient setting, as you are likely to be discussing most of the patients you see in clinic, particularly the new referrals. You are required to obtain a minimum of 4 CBDs or mini-CAXs. However, as with the ACAT, we suggest obtaining more than this, as it will provide more evidence to support your progression through the training program, as well as giving you the opportunity to receive feedback from an experienced trainer. You should also be familiar with the Mini Clinical Evaluation Exercise, or mini-CAX. These assess your performance during a clinical encounter with a patient, focusing on skills such as history taking, examination, and communication. The encounter must be observed by the assessor. They are a good option during ward rounds, specialty reviews, and discussions with families, so be proactive to find these opportunities. Remember to ask the consultant beforehand to allow you to perform the review or discussion, and inform them that you would like to be assessed so they are aware. Again, you need a minimum of 4 mini-CAXs or CBDs per year, which can be made up of any combination of the two. The direct observation of procedural skills, or DOPS assessment, is used to evaluate your ability to perform a practical procedure. It needs to be directly observed and can occur in a simulated or real environment. There are two types of DOPS. Formative DOPS are performed when you are still learning a particular procedural skill and would like to keep a record of observed assessed performance for your development. Summative DOPS are the type required for final sign-off to demonstrate your competence to perform a procedure unsupervised. This is a necessary requirement for DC cardioversion, NG tube insertion, lumbar puncture, ascitic tap and pleural aspiration for fluid. The decision aid details exactly what is required of you for each procedure, and this can be found on the JRCP-TB website. Thank you for watching this video. For further information, visit the JRCP-TB website, where you can find the full curriculum, the rough guide to IMT Stage 1 training, a guide to using the e-portfolio, and a section of frequently asked questions. If you have any other queries, you can contact us using curriculum@jrcptb.org.uk or via the JRCP-TB Twitter account.